chair the session.
Good evening, everybody. I think we've come to the end of the session, almost last but second session. All of you might have been fully loaded with all the pediatric knowledge to pass the examination. So I'm not going to tax you much. I have only a lot of slides, photographs, and videos only. And when I was doing MD, the worst part I don't want to read in Nelson is the chapter on development, because a lot of things you have to memorize. So that was a difficulty. Now, looking at these pictures and slides, we'll feel that, okay, it is an interesting subject to learn. I just thought we learn more from our failures rather than successes. Before that, I just tell you, I like to thank the organizer for giving me this opportunity. Next 35 minutes, we are going to have a lecture and 10 minutes video, and followed by our PD, Dr. Sashir Ranjani, will demonstrate development assessment in 2 kids for 5 minutes. That's the program for the next 35 minutes. We learn more from our success than failures than successes. In fact, this child was attended, cesarean section was attended. I followed up the child up to 1 year, gave all the immunization. Every time they come, we check the weight and said, okay, baby is growing well and all. The family got transferred to North India. When they returned back to Chennai at 3 years, child came with hearing aid. I totally missed the hearing defect, which because routinely we don't assess the development in most of our clinic and outpatient department. Now the things are changing now. A lot of development assessment is going on now. This is one of the concepts given in a book called by Mary Sheridan. She is an authority in developmental pediatrics. See, it's not a very boring subject. It is just a recap of what has happened in the whole universe. All of the whole world, the life started with the monocellular organisms, then birds, animals, reptiles, monkey, and then last human being arrived in the field. It took 25 million years according to the Darwin. What has happened in 25 million years in the whole universe is compressed into 25 months in development. See, a child spends 10 months inside mother's womb. 15 months is the upper limit for a child to walk. All of us have started our life as zygote, monocellular organism. To have a walking child took 15 months outside the womb and 10 months inside the womb. So 25 million years is compressed in 25 months. Such a fantastic concept. So development is really interesting if you go through that. And don't think that all the developmentally delayed children, they don't contribute to society. This boy is called Passimoyer. Children who underwent tracheostomy after prolonged ventilation, they can't express, they can't talk. So this fellow designed, he had a tracheostomy. He had some myopathy, I think. He was bedridden, prolonged ventilation. He had tracheostomy. He designed a valve through which child can speak. A speech valve used for tracheostomy. So this is a child who made that, who designed that valve. So what is developmental screening and development assessment? Developmental screening, the word is something comparable to you want to identify children with congenital heart disease. So you go for a camp, you check all the schools to find out who are all children has got murmurs or who has breathing difficulty, exertional dyspnea. Then the child come referred to the hospital where you take an X-ray chest, you do ECG, echo, and then cardiology. So that is developmental assessment. So developmental screening is done for all children. That is all normal children. It's a very quick subjective assessment. Maybe 5 to 10 minutes only you can spend in a busy outpatient department. It is done by general pediatrician in the clinic. What is developmental assessment? There are a lot of developmental assessment tools like PALS, NALS. You have to undergo the course for 2-3 days or even sometime 1 week. You should be familiar with the tools. Then only you can apply these tools to identify the developmental delay in a child. That is a very detailed assessment. That is available only in a very few centers like CMC Vellore. I think ICH also has gotten now, and SRMC. There are only in few places they have a full developmental assessment where the developmental pediatrician is in the center of the assessment team, surrounded by all the specialists, ENT surgeon, ophthalmologist, orthopedic surgeon, all therapists. So what we are going to discuss now is only a developmental screening. Why should we assess a child? It is mainly to routine examination to identify any development delay and reassure the parents and give feedback for the obstetrician neonatologist and early diagnosis and prevention of disability. All of us are familiar with this scale, TDS scale. You keep a pen. Suppose a 10 months old child comes, you keep the pen. Whatever on the left side, child must be able to achieve it. On the right side is for the future. This is another scale. In TDS, you can only identify whether the child has got delay or not. We can't go beyond that. We may not know whether the delay is a gross motor delay or fine motor delay or language delay. This chart is, which is used in UK by Sundaralingam, one of the developmental specialists. This chart is quite useful. This chart is handed over to you with you now. It's a very simple chart. done at 6 weeks, 3 months, 6 months, 9 months, 1 year, 18 months, 2 to 2.5 years, 3 years. All of the simplicity of the chart is all the skills mentioned there are day-to-day activities like sitting or reaching for objects. Doesn't require a big training for the person who conduct that. So when you assess the child, probably you can go through that. There are 4 aspects of development. It's easily, conveniently divided into 4 fields, which are gross motor, which is body, posture, and large movements. Fine motor is fine movement and vision and manipulative skills, hearing and speech, social behavior, and spontaneous play. So we have to assess the child in all the 4 fields. So before assessing the child, you should take a brief history. The history should cover 3. One is the risk factors like prematurity, adverse perinatal events, or family history. You ask the mother any warning signs. Mother has got any concern for the development of the child. Mother's suspicion is very, very valuable. One day, a grandmother brought the child. In fact, most of the development delay are initially picked up only by grandmother, even before the pediatrician, because they go through the milestones of the child. This grandmother brought the child, about 9 months old child, saying that the Diwali day, lot of crackers are being, lot of sounds. But the child is very quietly sleeping. I really worried about it. The grandma was correct. The child had a hearing defect. So, if the mother has any concern or warning signs, please we have to attend to that. Physical examination, quick physical examination will give a clue. Most of the child with development delay will have either obesity or failure to thrive. Look for minor and major malformations. Look for neurocutaneous markers. Strabismus and cataract will usually be associated with developmental delay. Abnormal faces syndromes, neurometabolic problem. Child with development delay and organomegaly might have a neurometabolic problem. The neurological examination is important, but these 4 things are very much important to identify child development delay. One is symmetry of the movement. The child is moving all the time. 18 months old child moving only the right upper limb, not the left one. You should think the child might have a hemiparietal left side. Quality of the movement, whether it's clumsy or good. Primitive reflexes, they should disappear at particular age. And then postural responses. So just looking at the child, you will definitely say that the child has got scissoring, spasticity of both lower limbs. It doesn't take much time for us to assess that. So what are all the kits needed to assess, do the developmental assessment? 1-inch cubes, wooden cubes. If you ask any carpenter, he will make it for 10 rupees. You can collect it. Handbell, pencil and paper, small safe object, mainly for the pincer grabs. What do you think the small safe object that can be given to a child? Pardon? Chocolate is a big one, no? You can't give a pellet, no? You land up in airway and you have to call for an emergency. So you can give something which is edible, safer for the child. Generally dry grapes, the resin is used. Still more safer, which I learned from the Spastic Society, is the puffed rice, pori. The puffed rice is very nice for a pincer grass. If the child put it in the mouth, immediately will become soft. It won't cause any foreign body or a beautiful this thing. Safe, interesting toy without any colors or painting. Fluffy red wooden ball. Plus, you have smiling doctor. This fellow can definitely not assess the development of a child. What is the order in which you will test? Once I was in one of the examination and the examiner asked me to do a development assessment. I just started the gross motor because I read in that order only. Gross motor, fine motor, language, social. I just lifted the child cried, I failed in the examination. Because next 10 minutes child was crying, I couldn't do anything. So don't do that. Just observe the child. First start with the language without touching the child. Language, social, fine motor, last only gross motor. Just look at a child, spend some time making friendship with the child. Just observe the child, you will pick up a lot of milestones. If the child is raising the limbs and picking up a toy, we can definitely say the child is at least more than 6 months developmental age. Do quickly and efficiently, you can't spend a lot of time. It's something like a very, very short case. 5 minutes only you can take time to assess the development. There are some play events that they are related to the age. Mouthing, whatever you give, no child will put into the mouth. It has been in 6 months, 12 months. If you and I do it, that is absolutely wrong. Bruxism, when the child is awake, usually suggests mental subnormality or the class teacher is taking a very boring class. Hand regard, looking at the hand between 2 to 6 months. Casting, when you give some object, child will continuously throw this, whatever you give this. This happens between 1 to 1.5 years. Handedness, beyond 24 months in any child develop handedness. If you observe handedness in a child less than 2 years, it definitely other limb is paratic. Tripod way of holding pen. So when you take the pen, you hold like this. This is called tripod way of holding pen. That occurs only at 2.5 to 3 years. Earlier, they used to hold the pen like this only. Then drooling. When does the drooling stops? Drooling after 1 year. So when he was just taking class, mixing Tamil words, grandmother immediately told, sir, ஒரு வயசுக்கு அப்புறம் எச்சு ஒழுகாது, பேச ஆரம்பிச்சிடல பாப்பா. Very beautiful observation. So when does a child start talking? Child start talking when oropharyngeal tongue coordination is very good. So at that time child knows how to swallow the saliva. So by the child persistently has drooling of saliva beyond 1 year, suspect a pseudobulbar palsy, which may be a part of spastic quadriplegia. So how early you can test the hearing? You can do it even in a newborn. When you make noise, child will have a startle reflex. Startle, blinks, screw up the eyes, cries. That's what startle. If the child is already moving, when you make a noise, child will freeze for a moment. That is another observation that child definitely is hearing. Then comes a distraction hearing test, which is routinely done between 9 to 18 months, and other tests are the standard test. Vision, how early you can assess the vision? You take the baby and look at the baby, take your face very close to the baby. Baby will look at it briefly for a moment, or ask the mother, when the baby will be looking at the mother for a short period. By 2 months, we show a red, bright object, child will follow through 90 centimeters. At 3 months, he can follow through 180 centimeters. 10 months, child can pick up the raisin. 1 year, child will pick up the hundreds and thousands. That is described in the Western books. In our language, it is something like a pallimittai. It's a very small, like mustard, like candies are there in the villages. That is a small one. Child can look at it and pick it up at 1 year. These are the various. Our standard Sullen chart can be used only beyond 5 years, not earlier. This is the hundreds and thousands. The cubes are very useful to assess the fine motor. The mature pincer grasp will develop somewhere between 10 to 12 months. If we give at 12 months, we give the cubes, 12 to 15 months, child will bang the cubes. Can build a tower of 2 cubes by 15 months. Of course, it is not in our culture. We don't allow our children to play with the cubes. But most of the Western countries, they use cubes to play for the child play. You can build a tower of 2 cubes at 15 months, 3 at 18 months, 6 at 2 years, and 9 at 3 years. You can make a train without chimney. Train means you can arrange 3 cubes together, and then if you keep one over the first one, that is called chimney. Train with chimney at 2 years, with chimney at 2.5 years, without chimney 2 years. Then you can make a bridge, gate. These are the things which are generally used for developmental assessment, for a fine motor assessment. Now we will show you some of the pictures. In a newborn, normally in the prone position, head will not be in the trunk line. By 6 weeks, head will be in the same plane like trunk. 18 weeks, head is held up. Beyond 12 weeks, the child shows an inverted U like this. It is definitely indicative of a floppy child like SMA. At 4 weeks, we lift the child. There will be a complete head lock and lifting. Momentarily, child can hold the head for some time. By 2 months, partial head lock, but 4 months, completely head control should have been achieved. When you put a child in prone position, it is a protective mechanism. Child can lift the chin off for a few minutes, mainly to protect the airway. And then between 12 weeks, that is 3 months, child can raise the head and trunk with supporting with the forearm, called the forearm support. At 24 weeks, at 6 months, it is hand support. I was given only 15 minutes time, so I will just rush up. You can just look at the pictures. It's called a hand regard. Even a blind child can look at the palm. It's not related to the vision. This is creeping, 44 weeks. 52 weeks is bear walk, where the child will creep, something like creep using the hand and feet. This is a very important thing. When you give the cubes, by 6 months, child will pick up the cubes with all the 5 fingers, called palmar grasp. Scoop with an ulnar border, hold with all the 5 fingers, that is palmar grasp. 8 months, intermediate grasp using 3 fingers, and 1 year child will have a mature grasp. 6 months, 8 months, 10 to 12 months. By 10 months, child will have a good pincer grasp. Child will point with an index finger, pick up the small object, that is pincer grasp. Pincer grasp indicates the child has got a very good fine motor development. This is peekaboo. This is playing pat a cake. நம்மள வந்து கும்மி அடிக்கிறதுல clapping. Pat a cake is a Western terminology. Forward parachute. How early you can identify hemiplegia in an infant? A child having a persistent grasp reflexes, cortical thumb. Generally, by 3 months, child must be able to open the hand spontaneously. There is no spontaneous hand opening beyond 3 months. That means spasticity of this limb. And second, what you can do is, by 6 months, child must be able to reach for an object. Persistently, child is reaching only with one hand. That means other side is paratic. Third is, you lift the child and dip the child down as if child is going to fall down. Child will outstretch the hands, mainly for a protective mechanism. If the child does only with the right hand, left hand doesn't use, that means spasticity of the left upper limb. So, downward parachute or forward parachute reflex. Forward parachute reflex is very useful to identify spasticity of the upper limbs. Downward parachute means you lift the child up and then gradually come down. Child may not be able to stand at 6 months or 9 months, but able to support the trunk, head, support the body momentarily. That's called downward parachute. So this is palmar grasp, rooting reflex, visual tracking. You show an object, child tracks for 90 degree or 180 degree. Concentrating and rattle, beginning of eye-hand coordination. You can look at a social smile at 3 to 4 weeks. So just looking at a child, very quickly you can assess. Child has got 6 months old child, good head control. So gross motor is good. Good eye contact, so vision is good. Good interaction, socially good. So it takes only hardly 2 minutes for you to assess. It doesn't take a big this thing. Only that you have to train your eyes and mind for that. So holding head and looking further away. Reaching out for object. It's a classical 6 months. Reach for object, transfer to other hand, putting into mouth. This is bearing weight on legs. About 8 months old child, 6 months old child. Lift the child, put it in mother's lap. Child momentarily support. That is called bearing weight. The child is not equal to standing. Bearing weight will not occur in a child with SMA or a floppy child. See, the dog is also bearing weight, no? Similarly. Turning sound of a rattle is almost like a distraction hearing test where you make the noise behind the child without giving visual clue. Child turns the head and looking for an object which creates the sound. That is distraction hearing test. Finding the hidden object. A 10-month child knows that object permanence. The object does not disappear. So child look for the object, turning the towel or turning the pillow. Communicating with gestures, initiated by 1 year or 15 months, they may not be express word, but they can indicate everything by indicating the fingers or any object. When you see a child, 4-year-old child walking like this, you will make the diagnosis of cerebral ataxia. Broad-based gait, balancing with both the hands, but is normal at 1 year. 1 year, typically when child starts walking, will have a broad base, supporting with both the hands. That is normal. This is typical ATNR, asymmetric turning neck reflex between 2 to 6 months. When the child turns the head to one side, at the same side, arm and leg will outstretch, contralateral limbs will flex. We'll show some videos. It's a 2-year-old boy asked to jump. He's jumping. So see how he is holding the pen. He's not holding like a tripod holding pen. He makes vertical strokes. I made the circle, but he didn't do that. The vertical stroke only he does it. Turning the pages in bunches by 1.5 years, but 2 years he may be able to turn the books in single pages. But if you give a thicker pages, not a routine book. Tracking, visual tracking.
Sanjay.
It's not ideal method. Ideally, it should be done in the floor, not done on the couch. Child may tend to fall. Sitting position in the floor only is ideal place. He was not interested. He's not reaching for objects. Five months. He's reaching for object but doesn't take the object. It's a crude palmar grasp. Use all the 5 fingers to hold it. They are not rare videos, no? Commonly you see across whenever you look at a child. Head above the trunk line. It doesn't form the U. It's got a good strength in lower limbs also. So follow for 90 degrees horizontally. Up and down. Definitely you can vouch the good vision of the child. Distraction hearing test, rough one. But he doesn't respond. Ideally it should be done in a soundproof room. cooing and thumping the both lower limbs. So definitely the child doesn't have floppiness. Hand opening is there. Trying to reach for object. This is hand support. 6 months. I'm trying to locate the sound.
It's not able to sit.
Just momentarily he froze, he was frozen momentarily after hearing the noise. Sometimes child may have good reach, but he must be interested in the object. You see that he is not picking up the wooden cube because it is not interesting for him. You have a cell phone, he will reach for it. See, that object is also should be interesting. You cannot dub this child with developmental delay. Use interesting object. This is for pincer grasp. Small object, show it in front of the face of the child. Give it to the mother. Ask him to take it, but he is not interested in taking it.
இல்ல பில்லிங் டர்ன் பண்றது எடுக்கணும் கரெக்ட்டா அதாவது சவுண்ட்
Crude distraction hearing test.
சொல்லும்போது பெட் பண்ணுங்க இப்போ பெட் பண்ணுங்க
He's turning to the side where the noise comes.
சென்டர் வாங்கிங்க அந்த
You
பொண்ணு
must avoid visual clues.
என்னடி அவனுக்கு தெரியாம
அப்படியே ஆட்டுங்க
This is a simple test for hearing.
தாதார எடுத்து கொடு அந்த விரல்ல பதியது எடுக்கணும் அப்படி
It's casting.
Good boy.
இப்படியே அப்படியே பார்க்கலாம்
Up to 18 months, generally they do it.
Good boy. Clap for
பை
So now we're gonna do
Saying bye bye at 15 months.
அப்படியே
1 year old boy.
sit
Sit.
just stand
Stand. Stand. Sit.
See how he is standing. Still not has full control.
no clap again clap
Clap.
thank you அந்த பேப்பர் எடுத்து சொல்லுங்க
How he is walking. It's a broad base. Saying bye bye. Holding a tumbler and comfortably drinking water.
காது
Where are the eyes, nose?
மூக்குங்க
பார்க்கலாம் பாடல
Climbing up the adult chair.
பார்க்கலாம் அப்படியே நான் பார்த்த விட படம்
Turning
ஹெல்ப் பண்ணாதீங்க அவளே பாருங்க
pages in bunches. About 18 months old child.
இது என்னது உள்ள என்னது இருக்குப்பா
Giving the cube.
தேங்க்ஸ்
Again, an 18 months old boy, vertical stroke,
லோன் தான்
putting into mouth water.
லாஸ்ட் ஒன்று எடுத்து
He's comfortably handling the spoon and tumbler, drinking water through that. Picking up the thread. These are all the skills given in the handouts given to you.
அச்சமாச்சு
அச்சா நீங்க போய் டியூஷன் போயா
Answering simple questions.
அச்சத்து அஸ்வினுங்க அஸ்வின்
அஸ்வினிங்கடா
Where is Ashwin? He's indicating himself.
அஸ்வின் எവിടെ சரி இறங்கி வீட்டு போகலாம் சொல்லுங்க அவன் இறங்கணும்
வீட்டு
Saying thank you.
எடுத்துக்கோ என்னது
Picking up the thread. It's also again 18 months old child. See how nicely pincer grasp is established.
என்ன இது? பாப்பாட தலை எங்க இருக்கு? தொட்டு காமி. தலை எங்க
Raise the
இருக்கு
head.
காமி? அங்க இருக்கா? நன்னா காமி. ஐயா. கண்ணு எங்க இருக்கு? கண்ணு. நன்னா சிமிட்டி காமி. கண்ணு எங்க இருக்கு? மூக்கு எங்க இருக்கு?
18 months identity body parts.
கிளாப் பண்ண சொல்லுங்க.
கை தட்டு.
These are some abnormal children. You can see the spasticity involving all the four limbs. 3-year-old child, head lag. See, the upper limb is moving well, lower limbs are spastic. Typical ATNR, ATNR. See the hand grasp, cortical thumb in both hands. See, classical ATNR, 3-year-old child, head lag. Still unable to sit, no head control. This boy has got, see the swinging movements are there only on the left side, no, right side is absent. When you put him under stress, the hemiparesis manifests. He's got right hemiparesis, see the splaying of the hand right side. When he was asked to run, the classical hemiplegic gait develops. See the right hand, flexed elbow. Chiatic phases, coarse phases, child has got global development delay, cortical thumb. Involved movements more look like an extrapyramidal type of cerebral palsy, tongue thrusting, involuntary movements, not looking at you. Next slide. Now this is another one, you can just use it mainly for adaptive milestones. It's called lock STD is a mnemonic. Vertical line 2 years, 2.5 years, horizontal line that is forms a L, O 3 years. Lock. C for cross at 4 years. Square, lock STD, S 4.5 years. Square, triangle at 5.5 years, 6.5 years, diamond. Lock STD is a mnemonic. I'll just rush through that. So when you end of the assessment, you make 3 decisions. You don't make only 2 decisions, normal or abnormal. Either you make abnormal, clear-cut abnormal, you refer the child. Clear-cut normal, send back the child. When you are not able to decide or the child is not cooperative, make the third decision of yellow. That is probably normal or doubtful. Ask for a re-examination. These are some of the books and people who helped me to make this. Thank you. Now we'll ask Dr. Sashi Ranjani. She will demonstrate 2 kits with whatever we have discussed now.
We'll be starting with the younger child. This is Master Ashwant. He is a 1 year, 3 months old child. So I think all of you have the paper with you. So we'll be following according to it. Initially, like how Sir said, we'll be starting with the language and social domain. So this child is 1 year, 3 months. We'll be testing both 18 months and 1 year. First, we'll start with 18 months. On the social, even as we are examined, you can see that the child is exploring his environment. You can offer him a spoon and a cup, always involve the mother while doing the developmental assessment. Spoon kudunga. He's more interested in the toys. Ball. And a few things you can ask by history. Like it says, takes off shoes and socks. So it may not be able to demonstrate everything during the examination. Amma inge parunga socks ella avane thanavi remove pannuvaana eduthiruvan. So this also is acceptable. You can ask history. Going on to the language, points to eyes, nose and mouth. Ashwant, கேட்டு பாருங்கம்மா.
ఓషంత్ కన్ను ఎక్కడపయ్యా? కన్ను ఎక్కడ? ఓషంత్ కన్ను చెప్పి. ఓషంత్ కన్నేదా? కన్ను ఎక్కడమ్మా? కన్ను ఎక్కడ?
Okay. And obey simple commands. You can ask the child to give something to the mother. Idu amma kuda kudu. He's giving the cube to the mother. And attempts to sing. Probably you can ask the mother if he sings. Paadala paadvanamma?
பாடுவான். ஐயோ, தொட்டியில் போட்டு தூங்க வைக்கிறச்சா அவனே ஆண்டு பாடிக்கிட்டே தூங்கிடுவான். நான் பாட வேண்டாம், ஆட்டி விட்டால் போகிறோம்.
Then coming to fine motor, turns pages in bunches. Ideally, you should use a thick page book. This is not the ideal book.
See how difficult to get it done. Casting. Our turn pannuvaana? Oh, no, pannuva. Okay. And going to gross motor, climbs upstairs with one hand held. Padiyala errana or kai pudichi padiyera. So certain things can be confirmed by history. Then you should also look at the danger signs. Like danger signs in 18 months would be not moving about to explore. But this child, you can see, is very active and exploring the surroundings and not saying single word by 21 months. This child is interacting with the mother. So at present, he has no danger signs. Warning signs. Warning signs.
Now we'll go on to the next child.
Vishnu. 2 years.
So this is a 2-year, 4 months old child. So again, going back to our chart. We'll start with the social. Plays alone and pulls down pants at toilet. This you can ask through history. Amma inga parunga toilet ku pona thana chedi kaltuvana. So the mother says yes. And can eat skillfully with a spoon. Spoon kudta thana saapduvana. So this also the mother says. And going on to the language, refers to self by name.
விஷ்ணு எங்க? விஷ்ணு எங்க இருக்கா? விஷ்ணு யாரு? யார் விஷ்ணு?
And is constantly asking names of objects and peoples. So when the presentation was actually going, he was there asking Adena, Idena. So he is constantly asking questions. Coming to fine motor, removes paper wrapping from chocolate. Vishnu?
Nowadays, even a 6 months old child will do this.
So he's actually removing the wrapper. Builds a tower of 8 bricks. He had already built a tower of 2-3 bricks here. And turns pages singly. Then going to gross motor, jumps in place and climbs up and descends stairs holding on to a rail. Vishnu? Amma, keera irungu. Va, va, வீட்டுக்கு வா.
நீ இறங்கு நீ இறங்கு
ஏறி பார்க்கலாம், சேர்ல ஏறிக்கோ, ஏறி எடுத்துக்கோ வந்து.
ஏறி உட்காந்துக்கோ விளையாடு.
And the warning signs, avoiding eye contact. He has good eye contact. Handedness before 2 years, he's already more than 2 years. And no sentences. He is interacting with the mother and speaking sentences with few words. So he's developmentally normal, appropriate for age.
Thank you. All of you can just definitely attempt before going for exams.
Thank you, sir. I request Dr. Vilvanathan to give memento to Dr. Thangavelu, please. Is the session on pathology slides by Dr. Rajendran. I request Dr. Rajendran to come on to the stadium for the session.
First few words when it's getting ready. I'm very proud of you all. It's a Sunday, 5:15, and you are all here rather than going to Matran or Tandavam. I think I have to thank the producers. They are making such a movies, so you are all forced to be here. And I want to give one gift to you. Will you all please stand up? Yes? Just stand up. Just give a big hands to yourself. Come on, louder. Yes, please sit. Now I'm sure you are all awake and alive at the end of 2 days. So I'm really proud of you. It's your attitude. And how many of you are going for the exam? I heard many of you are going for exam. All of you, very good. And I can assure you, all 100% here, you will clear the exam. Okay? And if you don't clear the exam, Julius promised me he will give you 5,000 rupees back. Double the amount which you paid. Okay? So with those short things, let us finish. It won't take more than 15 minutes. Or when it is 15 minutes, tell me, Julius, I will stop it. And only one more thing. Dr. Thangavelu has left. Sir, I remember, sir, you asked me when the people stop drooling. I want to tell you, if Amalapal comes, even at the age of 48, I will drool. So I don't agree with 1 year. Thank you, sir. It was a very nice, wonderful presentation. So when Julius told me they want to know about peripheral smear examination, I asked him, what are all the things I have to talk? Then he told it is for the exam. So examination of peripheral smear has become peripheral smear for examination. This is the game plan. Next 15 minutes, we will see what is the peripheral smear, what are the disorders of RBC, WBC platelets. We will end up with take-home message. And I always like to start with a pre-test and post-test. It's very simple. Okay, just to know how I am able to cross your blood-brain barrier and put something in your brain. Okay, and copying is strictly allowed, so you can be my guest. And just only one answer is right. Okay, so in what condition will you see this? Don't tell. Post-test we will tell the answer. Pre-test, okay, just mark it. Okay, in relation to what disease I will use these stills. Do you all know this? What is this movie? Apurva Sahodharal, great. This one? Panjatandram? I think it's Mumbai Express. I think he's having that hearing aid. Okay, and what is this movie? Tasavataram, okay. And we hope he will get a Vishwarupam in the future movies. Okay, so what disorder I will use this still to compare? Is it RBC, WBC or platelets? What lesion will be associated with this? What do you see here? Eosinophils, okay? In what condition you see eosinophilia? In all these four. There's only one condition associated with eosinophils. Platelet feature is seen in association with, because this will produce low platelets, and especially in the season of dengue, you will be very much worried, isn't it? So you have to know what is this condition, and then only you can correct it. This intracellular inclusion is characteristically seen in what? Okay? So you all sit back, relax, and next 20 minutes we will try to cover as much as possible. So peripheral smear, it's a window for the bone marrow. You cannot see the bone marrow directly in all the patients. It's an invasive procedure. So we take the peripheral smear because it's inexpensive, rapid, and reliable. And how to make a smear? This is a big thing. All my pediatric, even assistants, associate professors, they are not very comfortable. Okay, we send our technicians to make the smear. When a technician can make, why can't you make? Okay, it is very simple. The only thing is keep at 45 degrees, allow the fluid to run all over the edge of the glass slide here, edge of the glass slide, and then move it very smoothly as you are running knife over the butter. Okay, the thing is, when I started making peripheral smear, I give pressure on that. When you give pressure, the smears won't be well made. Okay, just pass it smoothly. And this is the best peripheral smear. It should have head, body, and tail. And we have to examine at the, some echo is coming, I think. So we have to examine at the junction of the tail and the body. Okay, because if you go to the head, it will have a lot of Rayleigh formation. It's very difficult. And if you go to the tail, it will be very much dilated. So this is the part of junction of body and tail you have to examine. And we have to have a systematic approach. I heard you will be having slides in the exam. Okay, so you have to have systematic things. You have to look for 4 things. Look at the RBC, look at the WBC, look at the platelets and any parasites. Okay, in the RBC you see the distribution, quantity, size, shape, what is the pallor. Normal RBC, the central pallor should be 1/3. If it is more than 1/3 of the cell, it's hypochromic. Okay, and previously we used the term hyperchromic, now it is not used. Shape, pallor, premature forms, inclusions and organisms. In the WBC, look for number, differential count, premature forms, inclusions or increase in number of cells. Platelets, how much is the platelet, what is the size of the platelet. Organisms, we want to see intracellular and extracellular, and we concentrate mainly on 2 organisms. One is microfilaria, other one is malaria. Erythrocyte, you all know there is only 2 things, Rayleigh formation and agglutination. This is the best example of Rayleigh formation. We all call it as stack of coins. All the RBCs are sticking to one each other, and this is also Rayleigh formation. These patients will have increased fibrinogen in their level or increased proteins. That's why in multiple myeloma you see Rayleigh formation. The other RBC quantitative disorders are aplastic anemia and polycythemia. What do you think about this? This is the marrow biopsy. This is the peripheral smear, and marrow is totally hypocellular and only lymphocytes are there. Even peripheral smear would show only few lymphocytes, so this is aplastic anemia. Here RBCs are increased in number and they look very much crowded, so this is diagnostic of polycythemia. If you have any questions, I am going slightly faster so that you can leave in time. If you have any questions, please raise your hand, we will clarify. And if you raise your hand, others will kill you. Be careful about that. And the third thing, variation in RBC size and shape. Okay, anisocytosis when there is variation in size, poikilocytosis when there is variation in shape, and hypochromasia when increased central pallor. Okay, this is where we use RBCs. We divide them microcytic, normocytic.